This podcast is sponsored by Zoll LifeVest. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey there, CardioNerds. I hope you're ready for an episode packed with knowledge as we decode some of the mysteries of cardiomyopathy. I'm Teodora Donisan, a second-year cardiology fellow at Mayo Clinic in Rochester, and it is my distinct pleasure to join the stellar team discussing about restrictive cardiomyopathy today. I will start by introducing Dr. Jenna Skowronski, a third-year cardiology fellow at the UPMC and the CardioNerds Heart Failure Committee Chair. She's interested in the integration of advanced heart failure in transplant cardiology and women's health cardioobstetrics, and will soon be at Vanderbilt for Advanced Heart Failure and Transplant Cardiology Fellowship while finishing her master's in medical education.
Thanks, Teo. I have the pleasure of introducing Dr. Johnny Hourmozdi, a third-year cardiology fellow and CardioNerds ambassador from Northwestern University. Johnny is also a current artificial intelligence and cardiovascular disease fellow and a graduate of the medical humanities and bioethics program at Northwestern. He is interested in the intersection of artificial intelligence and bioethics and will be staying at Northwestern for advanced heart failure and transplant cardiology fellowship next year.
Thank you, Jenna. I've been really looking forward to tonight's discussion with none other than Dr. Steve Ommen, the medical director of the Mayo Hypertrophic Cardiomyopathy Clinic in Rochester. Dr. Ommen is a pioneer and a leading figure in the specialized realm of hypertrophic cardiomyopathy. As the driving force behind the largest and longest continuous single-centered dedicated to hypertrophic cardiomyopathy, he has been actively shaping the landscape of clinical care and research for patients with hypertrophic cardiomyopathy for over 2 decades. Not only has Dr. Ommen been at the forefront of clinical care, but he has also been a trailblazer in the realm of national practice guidelines for hypertrophic cardiomyopathy. His leadership has not gone unnoticed, and he's been honored with awards for clinical care, individual excellence, and team excellence, and we couldn't be happier to have him here with us tonight.
Thank you for having me.
Dr. Ommen, we're so thrilled to have you here, and we have some cases from the CardioNerds Clinic we'd love to discuss with you. So if it's okay, we're going to jump into the first one.
Fantastic. Let's do it.
Miss Mava is a 48-year-old woman without a significant past medical history. She was referred by her PCP to our clinic with progressive dyspnea when going upstairs, an occasional sensation of abdominal fullness. She also describes occasional lightheadedness with activity, but denies any syncope. On our physical exam, she's noted to have a soft systolic ejection murmur at the apex, which increases with the squat to stand maneuver, an S4, and JVP to 12 centimeters with a rapid Y descent. Her PCP had ordered an echo prior to the visit, which showed an LVEF of 60%, severe left atrial enlargement, an A/E ratio of 2.5 with an averaged E prime of 6, and a comment on apical wall thickening. Dr. Ommen, what's your differential at this time, and what other questions should we be asking our patient?
Yeah, it's a really interesting case. Thanks for bringing that up. So, as Nishimura always tells us, make sure you do the physical and history first before you get the testing. And so I think we do need to know some things about any past medical history for her and family history in particular. So is there any family history of heart disease and in particular heart failure syndromes? And has she had any personal history of prior cardiac symptoms? Has she had cancers in the past, received chemotherapy agents, received radiation to her chest for anything? All of those things could potentially make you think that could this be a generic cardiomyopathy, a restrictive cardiomyopathy, or is this with the apical wall thickening on your echocardiogram, a version of apical hypertrophic cardiomyopathy?
Thank you so much for going over your initial thoughts, Dr. Ommen. And so I really loved your pearl, physical before testing, and focus on family history, past medical history to kind of guide your differential further. When you do think about initial workup, what tests do you usually order?
Yeah, I think in this case in particular, it's interesting. You have a JBP with a rapid descent and an S4. So you're thinking that there's either some sort of right heart failure or restrictive type filling pattern. But remember, restrictive filling is most commonly due to dilated cardiomyopathy or ischemic heart disease even. So restrictive cardiomyopathies are more rare, but you're definitely going to want to get an echocardiogram for this type of patient. You're going to want to get an EKG. There's physical findings there, voltage changes that might be important, either high or very low, rhythm abnormalities. You might be able to see the atrial enlargement on the ECG. So you're going to want to get those probably as your initial tests.
Dr. Ommen, I actually have one more question, if I may. At what point do you consider MRI or invasive hemodynamic testing?
Yeah. So you get MRI in particular. Let's talk about that first. If the echocardiographic imaging is inconclusive, either because of suboptimal imaging characteristics in an individual patient, or that simply didn't give you a full answer, then getting a CMR can be helpful in getting a better idea for things like wall thickness, chamber sizes, those types of things. And then obviously when you do gadolinium enhancement imaging, there are specific patterns that in some instances are specific for hypertrophic cardiomyopathy. There's other kind of more non-specific, non-ischemic cardiomyopathy findings with more myocardial enhancement. So it gives you some other clues, but it usually is an adjunct to echocardiographic imaging. And I would say that increasingly many patients are getting both echo and CMR to kind of get to diagnostic fidelity. In terms of doing invasive hemodynamics, really the main times you do that, your clinical impression from the history and physical and your diagnostic testing on the echocardiogram and CMR aren't concordant. If you're not sure, gosh, is this purely HCM? Why does this person have heart failure symptoms? And you're not getting concordant answers from the non-invasive testing, well, then invasive hemodynamics can be very helpful. My colleagues that work in the cath lab obviously call it the table of truth because they think that's where the ultimate answers are obtained. And then obviously, if you're talking about, for several of you who are going into advanced heart failure, you're talking about patients who are not responding to therapies, guideline-directed medical therapy for heart failure, well, often you need to get invasive hemodynamics to inform your decisions in terms of more diuresis, less diuresis, pulmonary hypertension responsiveness, all those kind of things when you get into the advanced heart failure ward. But as part of initial diagnostics, it's when your clinical impression and your non-invasive studies aren't giving you a clear answer.
Thanks so much for that, Dr. Ommen. That's a really great summary of so many good learning points from that case, and especially a reminder of how much information we can get from a history and physical exam to help guide us as we're thinking about more advanced testing. Important point and a really great case to demonstrate that. Here's our next case. Mr. LV is a 25-year-old man who was diagnosed with hypertrophic cardiomyopathy when he started experiencing dyspnea while playing hockey in high school. His most recent stress echo showed an LVOT gradient of 40 millimeters of mercury at rest and 75 millimeters of mercury with exercise, as well as a septal wall thickness of 25 millimeters. His current medical regimen includes metoprolol succinate 100 milligrams daily and disopyramide 300 milligrams twice daily with continued NYHA class 2 symptoms. He's frustrated by his continued symptoms and he wants to discuss additional treatment options. And he's also wondering if he's able to play pickup hockey on the weekends. Dr. Ommen, how would you frame your counseling on therapies for this young symptomatic patient? I'm really curious to hear your thoughts on exercise here. I think a lot of us worry about these patients exercising, and I'm interested to hear how you would counsel him.
This is a great case and great questions. Whenever I see a new patient in the HCM clinic, there are a few things that we want to make sure we cover every time. And some of that leads directly to your questions. But one of the things that we like to talk about is that the general prognosis in HCM is not awful. Patients, get scared. They're looking on the internet. They see all the things that they might have to consider, and they think that's all going to happen to them. So I usually start by reminding patients that on average, patients with HCM live a normal number of years, doing normal things, and die from something else. We also want to make sure that we talk to them about their family and screening their family members because it can be familial. Can be autosomal dominant. And so that we talk to all our patients about genetic testing or echocardiographic-based surveillance as part of screening. The third major topic that I like to talk about is the risk for sudden cardiac death. And I think we'll get into that in more detail in general. The fourth big topic is on treatments. When are treatments necessary, and what do we hope for the patient in terms of physical activity? So those 5 main categories are what I want every patient who comes to the HCM clinic to understand when they're done with their interaction with us. So we would address those things with this young patient, all of them. He's obviously now expressing in the question that he's not happy with his class 2 symptoms and the fact that he's on a couple of medications that aren't doing that job. So first of all, I would say our goals for him are to get him back to be able to exercise like the rest of us are supposed to. And we can unpack that as part of this discussion too. But that's our goal. It's for our patients to be able to be active, participating, healthy individuals that don't have to worry about whether they're going to have symptoms if they go out for a hike with their friends or if they're traveling with family. They should be able to feel confident that they can handle that. And if they can't do that on their current therapies, then we need to consider something else. Now, this patient, interestingly, is already kind of on tier 2 therapy. He is on beta blocker, which either that or one of the non-dihydropyridine class calcium channel blockers will be level 1 therapy, but he's already also on disopyramide and still not satisfactory. So at this point, he really has 3 therapies that we should talk to him about. One of them is cardiac myosin inhibitor, with mavacamten being the first one that's FDA approved. That is going to be an option to talk to him about. We will also talk to him about mechanical relief of his mechanical obstruction, either through surgical myectomy or alcohol septal ablation. And we would go through the expectations for each of those. Mavacamten is new. It would replace the disopyramide if we were going to go that route with him. We would discontinue that, let it wash out. He could probably be on some metoprolol and the mavacamten. It is a once-a-day medication without a lot of side effects. It doesn't affect heart rate and blood pressure in most patients. But in the package insert, there was about a 20% rate of some degree of lightheadedness that patients experienced in the trials. Not necessarily so bad that they felt a need to stop the drug, however. When you look closely at the trials that have been published, about 30% of patients get a tremendous improvement in their symptoms. Another 30% get some improvement in their symptoms. And then the last 30% either don't get better, or 10%, the drug is such a potent negative inotrope that it drops their EF to less than 50%. So the drug has to be at least temporarily, if not permanently, discontinued. As an alternative to that, surgical myectomy, when done at an experienced center, has a success rate of 90 to 95% with a durable result. The muscle doesn't regrow, but it is heart surgery. It's a full sternotomy. The risk of scary things like stroke or death are less than 0.5%, bleeding and infection 1 to 2%, pacemaker maybe up to 3%. But it is kind of the ultimate option. The surgeon can be a craftsman in remodeling that patient's anatomy for exactly what that anatomy needs. And then lastly, generally speaking, for symptomatic patients, alcohol septal ablation is also an option. The success rate of that is about 75%, maybe up to 85% if you do more than one ablation to target the area. The stroke and mortality rates are about the same. There's a higher rate of pacemaker with an ablation on the order of 5 to 10%, but obviously no sternotomy, shorter hospital stay, quicker return to activities. So those are the general principles when we talk about management of residual symptoms due to obstructive HCM. Now, when someone as young as 25, like this patient, we don't usually lean into doing alcohol septal ablation because we're concerned about the long-term ramifications of the scar. But we also have data from our own experience here. Cleveland Clinic has published similar data where in younger patients who are wishing to be more active, the robustness of a surgical myectomy at an experienced center provides better long-term symptom-free survival. So for this young person, he's probably more likely in a decision between, do I want to keep on trying medications, mavacamten, or would I rather switch and maybe have an opportunity to stop taking medications and get a one-time operation that's going to be durable? And that's really the conversation we would have with him at this point.
Thank you so much. Really incredible points. I just wanted to probe a little bit further into that question our patient had about exercise here. How would you counsel him in particular about playing some pickup hockey over the weekends?
Yeah, it's a really great question. And it's a long story about sport, exercise, and HCM. The current recommendations are that people with hypertrophic cardiomyopathy should include exercise as a regular part of a healthy lifestyle. And the question is, what intensity of exercise should they do? And this all stems back to some studies that were done. The original publication looked at dead athletes and found that hypertrophic cardiomyopathy was overrepresented. So the conclusion, which was appropriate, was it was higher risk to be an athlete with hypertrophic cardiomyopathy. Unfortunately, I think that kind of got generalized in a way that led to not only was it high risk to be an HCM athlete, it was high risk to be an intense exerciser with HCM, which got generalized to it was high risk to exercise with HCM. And we turned a generation of HCM patients into HCM cardiometabolic syndrome patients, which is actually a worse combination. That original study does tell us that it is higher risk to be an athlete with HCM, but probably compared to athletes without HCM. And that's not the choice the patient gets to make. The question a patient wants to know is, if I have HCM, is it higher risk for me to be athletic or not? And we've got data emerging in the more recent years that show among patients with HCM, when your sample is HCM patients, and you look at gradations of physical activity as measured by activity trackers, we're not seeing any signal for increased adverse events in the more active individuals than the less active individuals. There was a trial done out of the University of Michigan that showed that patients with HCM who engaged in physical activity were able to improve their VO2, just like other human beings are able to improve their VO2 through exercise. And in the most recent LIVE HCM trial, where it looked at all these activity levels, those people that achieved at least 6 minutes of activity for at least 60 minutes were not having adverse outcomes compared to people who were less vigorously exercising. So the way that we put that together in the 2020 guidelines was that we felt like HCM patients should be counseled to be active individuals as part of a healthy, holistic human lifestyle, and that probably the best intensity is in the low to moderate intensity activity zone. That can include both cardiorespiratory exercise, but that can also include some resistance training as long as the patient is breathing normally, not doing Valsalvas, not doing powerlifting or 1-rep maxes, those types of things. There are some small studies that are looking at high intensity interval training in patients with HCM. And in the abstracts that we've seen, there has not been a signal for bad outcomes, but the studies are small and they haven't been published in a peer-reviewed journal yet. So it's hard to draw conclusions there. So I usually talk to my patients about light to moderate intensity exercise. In terms of this gentleman wanting to play hockey, I always ask the question, and usually with the patient's family or partner or whoever's in the room who knows them best, what does it mean to you to play hockey on the weekend? Are you the kind of patient who you need to win? Because if you have to win when you're out there, it's probably not an activity that you might want to subject yourself to, because the most successful athletes are the ones who ignore signals from their body screaming at them to stop in order to get the puck, get a touchdown, play defense better. They exert themselves beyond when most of us get stop signals from our body and maintain fine motor skills. If, on the other hand, he's like, no, I just want to go out, skate around with my buddies. It's not competitive. It's fun. It's relaxed. Then it's probably okay. But it's always a discussion about, you have to think about what your motivation is when you're there on the ice.
Dr. Ommen, thank you so much for that. When I listen to you speak about that, I think I come back to kind of core principles of exercise is usually good for our patients, and shared decision-making and understanding our patients' motivations is never a bad thing and always helpful. So thank you.
Yeah, absolutely. I agree with that completely.
Okay, we have another case for you. Since this has been so wonderful for us, we want to hear more. For our next case, Miss OT is a 42-year-old woman, and she was recently diagnosed with hypertrophic cardiomyopathy. She has 2 children, ages 15 and 12, and she also has 2 siblings in their 40s. She has not undergone genetic testing at this point. And so Miss OT presents to your clinic to discuss the benefits of undergoing genetic testing. And she's also asking if her 15-year-old should be screened because she is a competitive swimmer. So, Dr. Ommen, I think this case actually brings up 3 main questions that I'd love to hear your thoughts on. The first is, what is the utility of genetic testing in our patients? does genetic testing impact therapy or ICD placement? And then the third is, what should our approach be to familial screening here?
Those are great questions. So, as I mentioned with the previous case, talking about screening the family members is like a core thing that we discuss with every family when they come to see us. And we do think the family should be screened. And we all offer all of our patients genetic testing as one of the options to do that. And if they don't want to do genetic testing, or if the gene panel does not come back with a pathogenic or likely pathogenic variant, then we switch to an imaging surveillance protocol. With genetic testing, you test the individual who has clinical HCM and then try to identify if we have one of those pathogenic or likely pathogenic variants. And if they do, then you can test their first degree relatives and do cascade genetic testing. So you chase the positives around the family tree. Again, just as a sidebar, again, if the gene panel comes back as a VUS, variant of uncertain significance, or it comes back with no variants, we then tell the patient that their adult first degree relatives should get screening echoes every 5 years, and their children and adolescent family members, first degree relatives, would probably be screened annually. For this patient, both of them are 12 and 15, so they're essentially adolescents. We would definitely recommend screenings for both of these children. Screening single-digit age kids is a little bit more of a debate. Certainly, there are kids that are single digits who have clear HCM and have adverse consequences to it. So if a family chooses to screen, it's appropriate. You should never delay screening until beyond puberty, however. So 12 is kind of the latest you'd want to start screening in a child, but it's perfectly reasonable to screen them at a younger age. The genetic testing is mostly helpful for understanding who else in the family is at risk and needs to be followed more closely. In patients under the age of 16, however, some utility in helping with your second question, and that is decisions around ICD recommendations. So they're being a gene positive, and it doesn't matter which sarcomeric gene it is, but a gene positive individual who's that young has a higher risk for sudden cardiac death than a gene negative individual. And so there are tools available that can help incorporate that into a risk estimate and those types of things to help those families talk about whether or not that child might be offered an ICD. Currently, genetic testing does not impact our therapy decisions. Certainly, there is kind of just general, more cumulative compositive endpoints in patients who are gene positive, but there's no actionable result that you can use to change that. We will see that changing. There was recently announced the first ever patient was dosed with a myosin binding protein C specific gene therapy. And so if these therapies turn out and pan out, then at some point, then the specific genotype may mean the patient can get different therapies. So that's really our approach. We talk, first of all, the main thing is just finding out who else in the family is at risk. If they're a young person, 16 or under, it does influence ICD decisions, not in the adult population. And in the future, we may see gene therapies that would be predicated on the specific genotype.
Thank you for that great discussion of genetic testing. It's so important to acknowledge that this diagnosis affects not only our patients, but their families. And it was really cool to hear how there is a really exciting future with these gene therapies and how genetic testing may come to impact therapies. So at the moment, it sort of informs and helps you guide prognosis, but not necessarily decisions around therapy. Is that right?
That's right.
Awesome. Well, we have enjoyed talking to you so much. And we, of course, have one more case to try to squeeze some extra learning out of you. So without further ado, Mr. V is a 50-year-old man with known hypertrophic cardiomyopathy coming into the office to discuss the need for ICD placement. He has no personal history of syncope and no family members who have experienced sudden cardiac death. But on a recent cardiac MRI, his LVEF was 55% with an LV wall thickness of 28 millimeters and late gadolinium enhancement of 16%. He has had several Holter monitors without any NSVT. And so we're wondering, what are your thoughts on ICD placement for primary prevention in this patient? And how does his cardiac MRI result affect that decision? Would you still make the same recommendation if we had only looked at his echo?
Yeah, this is a really great teaching case. So this patient in the presentation has a class 2B indication for an ICD. And that is because of that extensive late gadolinium enhancement on his CMR. So a class 2B indication, the wording we use around that is the role of an ICD is uncertain, but it may be considered. So how do we approach that from a practical standpoint? Well, I think one of the things that we have to look at is that guidelines are that. Guidelines are not policy and guidelines are not law. And what we want to do is make sure that we all kind of have the same sense of what north is and we're advising patients around their risk. If this patient is coming to see us, in the first sentence you said, because he wants to discuss needs for ICD, I'm going to sense that he's concerned and he's anxious about his risk for ICD. So we're going to want to talk about that in detail. And so the way that I approach this is having any of the risk markers that we know of makes the patient eligible for an ICD. But there are different levels of eligibility. And then we can also use risk calculators to help frame the magnitude of the risk to help that patient understand if they're tolerant of that risk or intolerant of that risk. So again, the main risk factors that we're looking at are, apart from secondary prevention devices, so the patient hasn't had an event, is a family history of cardiac arrest due to hypertrophic cardiomyopathy, massive hypertrophy, arrhythmic syncope or arrhythmic suspected syncope, non-sustained ventricular tachycardia, low ejection fraction, apical aneurysm, and extensive late gadolinium enhancement. So any one of those renders a patient eligible for an ICD. And I usually tell my patients that. I say, we have 3 layers of eligibility for ICDs among patients with HCM like you. The top one, where everyone thinks that patient should get an ICD, for all intents and purposes in HCM, are patients who have had a clinical event. They've been resuscitated. Everyone thinks that's a class 1. That patient should get an ICD. The next level down, which are the people with massive hypertrophy or scary syncope, family history, that's the class 2A indication where it is reasonable for that patient to get an ICD. But I also point out a reasonable person can say no, thank you, after a discussion where we understand goals, risks, fears, risk tolerance, et cetera. And the lower level of eligibility is this class 2B, where the role is uncertain, but it can be considered, particularly if a person is going to change their lifestyle because they're so afraid of dying suddenly. Sometimes you can make a big difference in a person's life by giving them a safety net. And so we talk about those kind of things. And then I do use the HCM risk calculator, not to make the decision about whether an ICD goes in or not, but to communicate with the patient what their risk is. Because it's surprising how often patients come in and think they're likely to experience sudden death, when in reality, the risk for sudden cardiac death is almost always single digits. But when you put this person's number into the calculator, it gives you that magnitude of risk. And the calculator is helpful in this particular case because 28 millimeters is a uncomfortable wall thickness, because it doesn't meet the magic line in the sand of 30 millimeters. But you all have looked at echocardiograms and CMRs, and 28 is not different than 31, but it falls on the wrong side of the tracks if you're one of those. And so what the risk calculator considers wall thickness as a continuous variable. And so that gets incorporated into that risk estimate. The patient's age gets incorporated into that risk estimate. And so you can tell this patient that they have X% risk of sudden cardiac death and a class 2B, or the lowest level of eligibility, and then talk through the pros and cons, logistics of ICD placement and maintenance for that patient, and help them make a decision. And there are some patients who hear that risk estimate and say, gosh, that scares me. When can I get it scheduled? And other patients who will say, I'm okay with that risk and I'd rather not have a device. So that's back to one of the earlier comments we had. This is like the ultimate shared decision-making conversation where you understand what the patient's fears are or where they have lack of fear, and use all the tools at your disposal to communicate their specific situation to them.
Dr. Ommen, thank you so much for that. This was just such an amazing conversation that I think really got to a lot of the nuance of restrictive cardiomyopathy, but also specifically hypertrophic cardiomyopathy. If it's okay with you, I'm just going to tell you what some of my main takeaways are and see if I learned appropriately from you.
Okay.
As you just highlighted, I'm really going to bookend that talking with our patients and spending time with them and understanding what drives them and what they're afraid of and what is important to them really feels like the North Star of care in these patients, and really I think any patient. But I think our first case, we started with how important our physical history was. And then I think in our last case, we kind of ended with how important it is to have a really nuanced conversation that gets to our patients' wants and needs surrounding ICD. And so that's a really big highlight for me. Something else that I took is whenever we think about therapies, having, again, kind of motivations of our patients and the symptoms that they're experiencing helps drive it, and understanding that mavacamten is something that can be integrated into a pharmacological therapy strategy at this point with a kind of varied response. But the surgical myectomy in a patient like our young hockey player is somebody that would probably benefit from a really good result at a center that is comfortable with the procedure. And then I loved whenever you spoke about exercise. I think the comment that you made was our patients do better whenever they're able to exercise and be healthy in that way than whenever they don't, which I think is such a great takeaway. And I finally, whenever we talk about ICDs, thinking about the kind of nuanced risk that comes with these patients and talking to them about different levels of risk and understanding them. So this was such a rich discussion for me. Johnny and Teo, I'd love to hear some of your takeaways from that too.
Was going to thank Dr. Ommen for the wonderful review. I did have one additional question to build on that patient we had with regards to the concern for sudden cardiac arrest risk assessment. And I was wondering, do you always get cardiac MRIs for all of your patients to help with that discussion?
Yeah, that's a really good question. So, I would say many or most patients end up with a CMR, but there's a few specific cases where you wouldn't need it. So, one, the patient who is deciding they are going to get an ICD already because they watched a family member die suddenly and they've got HCM, and that is one of the most heart wrenching risk factors you can have. And it is very motivating for that patient. So, they may decide, I'm going to get an ICD. There, the only reason why you would need an MRI is if you had diagnostic uncertainty about the underlying diagnosis. So maybe not necessary in some patients. And then in the opposite scenario, we have patients who will say, I'm not interested in ICD. Well, then doing an CMR for risk stratification often is not going to be helpful. So those would be reasons to not have to get one. But if they don't have other risk factors, getting that LGE assessment, or if you have any question about how thick the walls actually are, then CMR is a great way to help build out your knowledge base about that individual.
Thank you so much for going over that. That's very useful and actually reminds me of a case we had together. Actually, I was on consults and we curbsided you with a question and a patient who was getting a pacemaker for an alternative reason. And we were trying to decide as to whether we should add the ICT components to that as well. And when we were calculating the HCM SCT calculator, she was in the 2B category with a 4% risk of sudden cardiac death. And 4% wasn't that impressive. But when we spoke to you, you actually brought up the fact that there was some nuance, and she had two class 2B indications, which kind of increased her risk to about 8%. And that did actually impact our management. And she said, 8% is close to 10%, and I'm young and I don't want to die. That actually did change our decision. So thank you so much for going over that.
Yeah, and that's a really interesting case as well, because that patient is already crossing the barrier to getting hardware put in. And so then if you're going to get leads and a pulse generator anyway, well, then the bar to say, gosh, should that be an ICD? The bar probably lowers for many patients and many practitioners as well in that discussion, since you're already going to be implanting that patient.
Well, thank you so much. And I agree totally with Jenna's takeaways. I would add, as she said, I just loved how clear it is your passion for caring for these patients and how patient centered you are in your approach to counseling, just in how you were teaching us how to think about risk and pertaining to exercise and other things. It's clear that you really get to know your patient, and that's a key part of that patient centered care is eliciting their values. Are you the hockey player who plays to win, or are you the hockey player who's just kind of skating around? I just love that because I think that's such an important distinction, and trying to really be thoughtful and approach every patient as an individual and not just think about it as sort of a cookie cutter approach. It's really inspiring. I also will add, in keeping with that, genetic testing useful for cascade testing if there's a known pathogenic variant, but really understanding the modalities to screening for anyone with a variant of unknown significance or who doesn't have any variant identified, and how important it is to counsel patients, not just for themselves, but about the risks to their family. I'm sure that's really an important thing to patients as well. Really just a thoughtful discussion. I've had so much fun listening and learning alongside my fellow cardio nerds here.
That's great.
Dr. Ommen, it is my absolute pleasure to ask you the final question of the podcast. And the usual question we always ask is, what makes your heart flutter?
Well, I think when my Wi-Fi went down at the beginning of this podcast, I think I was having tachycardia at that point. I think, but I have two more serious ones, and one of them plays off of what you were all just talking. There is a moment that I see in clinic, at least weekly, if not daily, when patients come in to talk about their hypertrophic cardiomyopathy with fear and concern and confusion. And there's a moment during that dialogue where you see them suddenly grasp on and get what's happening to them. And you can see their shoulders go back, their confidence come up, and they just relax and then start to have that conversation that helps you make those decisions. And it's really an amazing thing to experience that with people when they've come in with so much fear. And then in my personal life, it is watching my two children succeed in life. Makes my heart flutter every time I think about it.
I love that. Wi-Fi issues aside, I guarantee you that none of us noticed. I think I speak for all of us when I say thank you so much, Dr. Ommen. Your time has meant so much to us. I'm sure our listeners will also appreciate everything you have to teach them. And we've just been so grateful to share this time with you and learn so much from you. So thank you so much.
Thank you. And thank you for all you do to help spread education.
Thank you for tuning in to this CardioNerd episode. The audio and editing for this episode was performed by me, Atefeh Ghorbanzadeh. I'm an intern in CardioNerd Academy House in Pollak and a research fellow at the Mayo Clinic. I invite you to check out our website for show notes and references. If you find this episode informative, please consider subscribing to CardioNerd on your favorite podcast platform and leaving us a review. It really helps us spread the word for our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views and expresses on our show and site do not reflect the opinion or policy of our employers. All CardioNerd content is planned, produced, and reviewed solely by CardioNerd. Stay tuned for more engaging conversation and exploration on our upcoming episodes. And now, it's time to make like S2 and split.